Assalamu alaikum. Today with clinical case, Mrs. Dota, who has come from Bangladesh to visit her daughter in UK. Since her arrival, she has been complaining of persistent cough. Examining her today, she has right-sided basal crepitations. I would appreciate your help with this matter and further treatment. You can start after sharing the timer. You ready?
Yes, inshallah.
Yeah, here you go.
Hello there.
Hello.
My name is Dr. Ahmed, one of treating doctor in the clinic today. May I confirm that you are Mrs. Dota?
Yes, doctor. I'm Dota.
Can you please confirm your age, please?
I'm 61 years old.
Mrs. Dota, we are here today to discuss some issues related to your health and examine you. Is it okay with you?
Yes, please, doctor.
It came to my knowledge that you have been complaining of cough. Can you tell me more about this?
Yes, doctor. I started to have a cough, which is now I have this cough also. It started, I think, 2 weeks ago, and now it's increasing. I try to take cough syrup, but it's not helping too much.
Okay, I'm sorry about that you have been through. I will help you as much as I can.
Okay, thank you.
Ms. Dota, have you noticed anything increase this cough?
No, doctor.
Is it the first time or you have previous attack?
No, this is the first time I'm having this cough.
Okay. This cough.
Yes.
Okay. Is it related to any specific time of the day?
No.
Have you noticed anything make it worse?
No.
Or make it better?
No, doctor. It's all the time increasing the frequency.
Okay. 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 Is it dry or contain film?
It's contain phlegm, doctor.
Okay. Can you tell me? Can you tell me more about this film? What is about amount?
It's normal as a 1 teaspoon at every.
What's the color?
It's green brownish, but yesterday I noticed blood in it.
Okay, I'm sorry about this, Miss Tota. Well, okay. Have you noticed any offensive odor or any offensive odor or in this film?
No.
Okay, Miss Tota, have you contacted with anyone have the same problem?
I'm not quite sure, doctor. I didn't notice that.
Or have you contacted with anyone has serious illness before?
No, I don't know. No, couldn't remember this.
Okay. Any noisy chest or with or any noisy chest?
No.
Any chest pain?
No.
Any stiffness? Any runny nose?
No runny nose.
Any blockage of one of your nose?
No blockage.
Okay. And shortness of breath?
Yes, I'm feeling also some shortness of breath on minimal exertion.
Have you noticed anything increase this shortness of breath?
No, I have only pain in my chest when I'm coughing.
Okay. Have you noticed anything improve this chest pain? I mean, when lying flat, I mean, or leaning forward?
No, I'm feeling this chest pain when I'm coughing, and I struggle with coughing, and I couldn't take my breath, and I'm having the same chest pain with the cough. But after the cough attack is a cough episode not present, I'm not having chest pain.
Okay. Okay. Any lower limb swelling?
No.
How before this short of breath, How many steps you can manage before feel this shortness of breath?
I was doing my daily activity normally before having this, but now on minimal exertion, I'm feeling short of breath.
Okay, and shortness of breath when lying down?
No,
Have you noticed any time? Did you this shortness of breath awaken up you from the sleep, catching your breath?
no, only if coughing. But sometimes before I'm tired from the coughing, I'm fell asleep waking. But if I'm waking at night and have this episode of cough, I'm having also the chest pain with it. But I think it's related to my cough because after that
Okay,
subside, I
okay,
sleep.
okay. Any headache?
No,
Any blurring of vision?
no,
Any weakness, any part in your body?
no,
Any loss of sensation?
no,
Any joint pain?
no,
Joint stiffness?
no,
Skin rash?
no.
Any tummy pain? Tummy distension?
Mm.
Have you noticed anyone become paler than before?
No, I didn't notice that.
Any changes in your color of your eyes?
No, doctor.
Okay, sorry, Ms. Data. Any high body temperature?
No, I don't have fever, but I think my daughter is telling me in the morning that she found the pillow soaked with my sweating.
Okay. Okay. Any weight changes or loss of weight?
Yes, I think I lost some weight.
Is it intent?
No, over the last 2 months, I think my clothes become loose.
Any loss of appetite?
I couldn't eat these days because the cough. I'm feeling tired.
Okay. Any lumps or bumps anywhere in your body?
I didn't notice.
Okay. What about your water work? Any changes in color or amount?
No.
Okay. Well, Miss Dota, okay. Any past medical illness you should be aware of?
Yes, I have many medical illness.
Mm-hmm.
I'm diabetes, 18,
Mm-hmm.
and at the beginning I was controlling it with diet.
Mm-hmm.
But in the last 5 years, the doctor gave me metformin. Okay.
Insulin or what? Sorry.
The doctor gave me metformin for this,
Okay.
and I think it's controlled now. And also,
Okay.
I'm having high blood pressure, diagnosed 12 years ago, and I'm taking.
Mm-hmm.
And I will show you the list now. And I was
Mm-hmm.
this gout. I was having. I got 2 times ankle swelling,
Mm-hmm.
and I've been diagnosed with acute gout. Okay.
Mm-hmm. Mm-hmm.
So my medication, I'm taking atenolol, ramipril, allopurinol, metformin, only this medication.
Mm-hmm. Okay. Okay. And what is the dose of Framipril?
2.5?
Any recent changes in the dose?
No,
Regarding high blood sugar, I mean diabetes, what is the last hemoglobin A1C? I mean the test that covered in the last 3 months?
I think it was 6.5.
Okay, good. Okay. So, Ms. Dot, what do you drink? Do you smoke?
No,
Do you drink alcohol?
never.
Okay. Do you drive?
No, I'm not driving. I'm here, I'm not driving, but sometimes I'm driving, but now I'm not. I'm here in the
Okay. What is your job?
I'm a housewife.
Okay. And you mentioned that this affects your daily. Now you're feeling short of breath, right?
Yes.
Okay. Can I examine you?
Yes, please.
Vital sign?
The vital signs normal.
Normal.
Mm,
Okay. Blood pressure sitting and standing.
normal.
Okay. Any temperature chart?
Normal temperature.
I would like to examine the hand for any clubbing.
No clubbing.
Okay. Any mouth examination?
Nothing.
Okay. neck examination, any raised GVP,
No trace GVP.
lymph nodes.
No lymph nodes.
Okay. Chest examination. I would like to start with the inspection. I mean, first of all, respiratory rate.
Normal.
Okay.
22, you can say.
22. Okay, general inspection, any moveless or deformity, side moveless? Hmm?
No.
Okay. Well, chest expansion,
Normal.
chest move, okay. Percussion note, any dullness area,
She has no. She has bilateral. She has right basal crepitation.
right? Basic grips. Okay. Is it fine or coarse grips?
It's fine.
Any changes with cuffing?
No change with cough.
Okay. This mainly in the right side.
On one side, on the right side, yes.
Okay. What about the trachea?
Central.
Central. Okay. Cardiovascular. Okay. Regarding the auscultation about air entry, any abnormal added sound like pleural rub, any findings like this?
No.
Okay. Back examination, any deformity?
No.
I would like to repeat the all examination of the anterior and the posterior chest. Any abnormal added findings apart from this basal inspiratory fine
No.
crepitations?
Only right crackles on the lower zone.
Only right crackles. Okay. Look. Okay. No clubbings are no clubbing at all.
No.
Okay. I would like to examine. Okay. Cardiovascular examination.
No.
Normal. What? Sorry. What was the BMI?
The body mass index.
Mm-hmm.
It's 26.
26. Okay. Okay. I have more questions, Miss Dota. Do you have any TARIS tool?
TARIS tool.
Yes.
What do you mean by TARIS tool, doctor?
I mean changes in the color and changes in bowel motions.
No.
Or black bowel motion.
No.
Okay. So what is your concern, Miss Dota?
I'm concerned about this cough. I'm having cancer.
Okay. I highly appreciate your concern, Ms. Dota, from what you said to me. And after examining you, you must probably have scarring on your lung. This scarring of the lung, given the symptoms that you have. This scarring has a many possibility. That is why we need to do some blood tests and investigate some blood tests and imaging to confirm our diagnosis and exclude others. At the mean, that is why, and then we will sit together to discuss proper plan of management, and which will be in the form of chest doctor, heart doctor,
2
specialized
minutes
nurse,
left.
heart doctor, and
what is the causes of scarring that I'm having, doctor? Is it cancer?
I highly appreciate your concern. Actually, cancer, one of the possibility we need to exclude, but for in your condition, most probably it's not related to the cancer. At the same time, we need to exclude the cancer. One of the possibility, there is a serious bug infection. Sometimes may cause lung disease scarring in the long run. The other possibility, there is even sometimes this scarring can be occur without any identified cause, which is called adiabatic pulmonary, which is called in medicine adiabatic pulmonary fibrosis. Don't bother yourself with this name, but at the end it causes scarring of the lung. Now, for now, we are considering this might be due to bug infection. That is why we need to run some blood tests to confirm our diagnosis and to exclude others. Do you have any other concern?
Will you admit me, or I can go home?
For now, we need to run some blood tests. If we confirm that this is due to bugs infection, we need to admit you, and this will be in the aside room, because if we confirm this because of bug infection, I'm afraid to say that it might transmit it from person to another. That is why we need to keep you in the hospital until to be sure that you are no longer contagious for the other persons. I hope you understand this point.
Okay.
Do you have any other concern?
No.
Okay,
Thank you.
time's up. Yeah, examiner question.
Okay, can you present your case?
This lady, with 8 years old lady, presented with a 2-week history of productive cough, and she has a background of type 2 diabetes and hypertension and gout arthritis. In the history, she has this productive cough, which is small in amount and color was blood stained. At the same time, she has history of weight loss and chest pain, which is pleuritic in nature. And also she has this chest and shortness of breath, mainly with exertion. On examination, in examination, my findings, she is tachypneic with respiratory rate of 22. She has fine inspiratory crackles that does not change with coughing, mainly in the lower loop. So my summary of my finding for this lady, she has symptoms suggestive of pulmonary fibrosis, lower lobe pulmonary fibrosis for differential diagnosis.
Okay. Okay, and so you said the differential diagnosis is pulmonary fibrosis, right? Any other differential in your mind?
Could be pneumonia.
Pneumonia.
But again, is that she has this for this short term, 2 weeks is not unlikely to develop for pneumonia to be causes fibrosis or signs of fibrosis.
Okay, and if this patient has a recent history of travel from Bangladesh, do you
Yes.
think any infection can come?
Yes, tuberculosis is one of the differential, but again, is that tuberculosis can cause upper lobe fibrosis, and since she has lower lobe fibrosis.
Okay, and tuberculosis can not cause lower lobe also fibrosis?
Can cause, but commonly can cause upper lobe fibrosis.
Okay, and what investigation you will do for this patient?
I will start with the routine investigation, complete a blood count, renal function test, liver function test, electrolytes and inflammatory markers. Also, I would like to do sputum for culture and sensitivity and acid-fast bacilli. I would like to do chest X-ray and high-resolution CT scan. At the same time, I would like to do echo. And in spite of that, I didn't find any. Actually, I didn't ask about second heart sound, but I would like to do echo for any complication. And yes.
Okay, and what is the treatment?
Pulmonary function test.
What's the treatment for this lady? What is the management plan for this lady?
Management, it depends on the treatment of underlying cause. If she has tuberculosis, I will start with antituberculous for 4 drugs, isoniazid, and ethambutol, pyrazinamide, and rifampicin for 2 months, and then after that continuation with rifampicin, isoniazid for 4 months. If the cause of idiopathic pulmonary fibrosis, I will do first bronchoalveolar lavage to determine is it steroid respondent or not.
Okay.
If
And
the cause of pneumonia, we start with antibiotic.
so what is the commonest cause of community acquired pneumonia in the UK?
In the UK, I'm not sure, but for general Streptococcus pneumonia.
Okay. And if the patient has TB, what is the extrapulmonary manifestation of TB?
Okay. I asked for tuberculoma. She didn't have any neurological signs. I asked about abdominal tuberculosis. There is no any bowel changes. I asked about joint pain. She has no joint pain for tuberculosis joint. I mean bone tuberculosis.
Okay. And do you know any side effect of anti-tuberculous medication?
Sorry?
The side effect of anti-tuberculous medication.
Okay, regarding the isoniazid can cause peripheral neuropathy, ethambutol cause optic neuritis, rifampicin is hepatotoxic, and pyrazinamide can cause gouty arthritis. I mean hyperuricemia.
Okay, good. Okay, I finished my question.
Okay, time is up. Yeah, good
Yeah.
question, and well done, Dr. Abdelmayer. Let's hear the comment. You can
So,
start, Dr. Sir. Yeah.
okay, is it a weird question? You are right. Usually TB can cause upper loop, but the patient has lower loop unilateral. So it also can be TB. In this case, this patient has a TB, okay? Because she's having night sweat, she has weight loss, and she's coming from an endemic area, which Bangladesh. I think this is the first differential, okay? Because for interstitial lung fibrosis, you couldn't see any other signs of rheumatoid or any other clue, but you have some differential for the TB, the night sweat. And I told you the cough is not changing with the crepitation is not changing with the cough. Because sometimes it's not changing if it's sometimes it's not changing and it's not written in the scenario that it has been changed with cough or no, but it can be changed with the cough. So this patient has open pulmonary TB. Your differential will be TB, the first differential, and then you can say community acquired pneumonia. And less likely it will be bronchogenic carcinoma, sarcoidosis, and also you need to exclude pulmonary embolism because the patient has a recent history of travel. Yes, she has only 1 week cough and some shortness of breath, but you can put it also in the differential. Pulmonary embolism in the lower of differential. Okay, and so this patient, as you said, need to be isolated because she has an open TB. You didn't say in the investigation that you will do for her. This patient is diabetic. You should say that you do for her the blood sugar and also lipid profile for her. Okay. You can ask the patient about also sexual risk. Okay, the HIV. I mean, you can ask.
Actually, I got confused for this patient. She is 80 years old. Should I also ask about HIV package?
60 years, you should ask. They are all sexual active till 80 years. Okay, so you should ask about the sexual activity.
She was 60, Doctor. You said 80 twice, but she's 60s.
Okay, okay.
And even till 80 years, you are sexually active till 80 and 90. There's a sexual activity here. There is no age limit for that. So you should ask about the HIV risk. Okay. The other thing, okay, so this patient, this is the differential. So you will do for her, you said, yes, you will do for her sputum, morning sputum for acid phosphorylated. And the CT and all these things that you say, the X-ray and all these things. Okay, so you didn't ask the patient why she came to the UK and who she's living with. She's living with her daughter. She's coming. She will tell you, I'm coming to help my daughter, which is pregnant in her last months of pregnancy. So I think if you suspect TB, you should trace the contact. Okay, you can tell her that. The other thing, you said right about the treatment. Yes, should be treated with rifampicin, INH, ethambutol, pyrazinamide for 2 months, and the rest of 4 months you will continue on rifampicin and INH. The side effect you said in the medication, the only rifampicin is hepatic enzyme inducer, it can change the color of body secretions, so she might have her tearing red and the urine red, so she doesn't need to worry about that. The INH can cause also optic neuritis, drug-induced lupus. Ethambutol, you said optic neuritis and can also cause peripheral neuropathy. And pyrazinamide can cause also, you said gout and hepatotoxicity sometimes. Okay, you said the extrapulmonary manifestation good, so it's tuberculosis, lymphadenitis, and also you need to say the spinal TB, the pod disease, which is commonly affects the thoracic spine. Okay, and she might have abdominal TB, miliary TB, genitourinary TB. So TB can spread all over the body. Okay, the commonest UK pathogen, you said right, the most one is streptococcal pneumonia, and then Haemophilus influenza, Mycoplasma, Legionella, Klebsiella. Okay, so I think the same commonest pathogens that we are seeing in COPD and the respiratory system. This is my comment. I know that it's a little weird scenario, but it was like this.
Thank you, Dr. Sarah.
Okay.
Yeah, it's common scenario by different way. Let's take the message from this scenario. Whenever you see Bangladesh, India in the scenario, so you have to think about TB, the first differential.
Yes.
You have to think about it, either to rule it out or to confirm it. The question you asked Dr. Abdelmenem, yes, it's almost to cover the TB, but still the night sweat, I guess he didn't ask the night sweat, but you asked for the loss weight or the weight loss.
But I told him
So
about
still about lymphadenopathy.
No, I told him that my daughter found my pillow soaked with sweating, so there is night sweat.
Okay. So, I mean, this is a sign for TB, should be put in the top of differential. Or cancer. So those symptoms or consider symptoms positive in cancer or TB. Sometimes lymphadenopathy, but if not, not necessary. Anyway, you have to think about TB, even she denied everything. And there is also blood in the sputum. You have to put it in the differential before any other infection, okay? So this is the first differential. Then the PE also here is very important. She said to you, I have leg swelling, even you suspect septic or gout arthritis. You have to ask for the PE or suspect PE as acute cause. Okay, this is the second differential. Other differential could be community acquired pneumonia. Patient has cough and loss of weight, travel history. Even if you ask more about travel, you have to ask about the staying way. Where did you stay, at hotel or with your friend or with your family? The contact of TB you ask already. Any contact with TB patient or sick patient with cough. Yeah, all this question makes sense for the examiner, so you have to ask them. Apart from this, you examine well. You did also screening for the system or relevant system, which is the chest. You ask all the possible question. Every question you ask for the chest. Orthopnea, dyspnea, chest pain, short of breath, noisy breathing, cough, and the phlegm, the color, the amount. All this question makes sense for this case, but the differential, you miss the TB or you put it down, but it should be in the first of your differential list. But it's still, you can get the mark because you try to screen about it. So it's okay for as a differential and the possible. And you manage already the patient, but please, whenever she asks you or anyone, they ask you what the management plan, start by multidisciplinary team approach. Don't manage by yourself. You are not chest doctor or not pulmonologist. So please tell him I will call for multidisciplinary team, including the pulmonology, infectious disease, and specialized nurse, respiratory therapist for possible also oxygen support or supplementation. And for sometimes ventilation if patient deteriorated. Isolation or not according to the suspicion. Once you suspected TB, you have to put the patient under isolation. and to do AFB, as you know, 3 samples, Q8 hours a day, then to roll out the OpenTB. If rolled out, you can remove the isolation. If no sputum, you have to induce sputum by some nebulizer of saline. If cannot be, you can do bronchoscopy for bronchoalveolar. Other community-acquired pneumonia cause, you have to put it in your mind, and you put it in the antibiotics coverage. So you will start by saying antibiotics according to the hospital policy, considering broad spectrum antibiotics. The possible organism, as Dr. Sarah said, yes, first Streptococcus, Haemophilus, as any COPD patient or asthma patient or any patient coming, unless you have some hint in the case, like patient was in a hotel, so you have to think about Legionella. Atypical symptoms, you have to think about Legionella also. If patient have dry cough and immunocompromised, you have to think about BCB pneumonia. This is the categorized of the chest infection. But in general, you did great. So this patient clear for TB. The night sweats and the loss of weight, don't forget this message. Always pointing to the TB or cancer. Cancer,
Yes.
in this case, you can put it but at the bottom, not in the top. Idiopathic pulmonary fibrosis, it's you will have, of course, definitely will have clubbing. Idiopathic pulmonary fibrosis patient will be presented with clubbing, or he will have, or she will have clubbing.
And no blood in the sputum if idiopathic pulmonary fibrosis.
Yeah, it will be dry cough. It was distracted or
Can be
distracting
if,
you.
if had superimposed infection can be presented with.
Yeah. But you have to put the infection in the top. Loss of
Yes.
weight is, you have to screen also loss of weight. How many kilogram over how long? I think you didn't ask, or he asked.
I told him I lost, but I told him
Yeah, he didn't tell, or he didn't ask. It's important to know, because significant weight loss, you have to think about TB or cancer. Okay.
okay. Just for revision for the TB cases, not in this, but if you have a patient, we'll do also for this patient, we should do not only the assay for diagnosis of TB, we'll do the Mantox test, which is the tuberculin, but it's not accurate. We'll do the IGRA, which is a quantiferon test,
Yes.
diagnostic. And if someone has IGRA positive and doesn't have symptoms, it could be this patient have latent TB. Okay.
Yes.
And the treatment for the latent TB by giving one medication for 6 months, which is INH, or
Rifampicin also, yes.
our rifampicin INH for 3 months.
Yeah, together or combined or single, yes.
Yes, and if it's TB meningitis, the treatment will be given for 12 months.
1 year, yes.
Yes, but I'm not quite sure for how long. All the 4 treatment will given. I'm not quite sure about for how long the 4.
4-4.
4 to 4.
Yeah.
So we'll give 4 medication in the first
4
month.
medication for 2 months, then 2 medication for 4 months. Total of 6 months.
No, but for the TB meningitis.
1 year, 1 year.
All the medication?
Yeah, I remember all the medication. The same regime of TB, pulmonary TB.
So you mean that we'll give the 4 medication for 2 months and
Yes.
medication for 3 years?
No, you mean specifically how many medication he will take? No,
Yes.
I'm not sure about how many medication and for how long, or we will redistribute the medication or not. I'm not sure. But
Me
I
too.
guess it's anti-TB for 1 year. This is
Yeah.
the answer. Or how many types? I am not sure.
Me
Sure.
too. Okay. And the other thing, we need chemoprophylaxis. So we, for the contact, if at home, no chemo for TB. There is chemoprophylaxis. I forget. No, for meningitis. Okay. No contact. We'll
No.
no, we'll try
Screen only,
screening. Yes,
tracing.
tracing only. Yes, you are right.
Yes.
Okay.
No isolation of the contact.
If open TB, should be isolated for 2 weeks.
And
2
notify.
weeks. Yes.
And
Yes. And
Noti-
notifiable disease, yes. Notifiable infection control, yes. And of course, infectious disease.
And she can be
And you have to
isolated
do
at home, right?
culture.
She should be isolated
after 2 weeks.
after 2 weeks and until she have one is a sputum culture, sputum for acid bacilli negative. Mostly 2 weeks, and
Yes.
after you lose the sputum, it's negative, so she can she's not infected.
Yes.
And she can be treated at home, right?
Yes, if she can able to be isolated at home, and there is
Uh-huh.
environment for isolation at home, she can be treated, but she will be followed by the TB nurse. She can do with her some video calls to assess her compliance with the medication and check for the side effects. So she,
DOT.
yes, but she
Di-
can be treated if the home circumstances for isolation are good.
Yes. Exactly.
So
Yeah.
I have one question.
Yes.
What is the sequence of investigation in suspected patient like this? First, we do sputum and the quantiferon test, or we go to direct to PCR either in sputum or step by step or together all. What should be the approach to confirm the diagnosis of process in suspected patient?
You will do sputum for acid fast bacilli, and also you will do culture for acid for acid fast for the TB.
Three culture.
Yes.
AFB, yes.
Yeah.
I
If
think
clear
nowadays
positive,
they go there for PCR.
yes, yeah, but you have to know is it infectious or not. TB PCR to know if it's already positive for TB. But if infectious or not, you have to do the AFB 3 samples.
Yes.
Okay, so if all these is positive, it's TB. If negative, you can do the next test as quantiferon and IGRA test. But if positive, it's clear TB. Sometimes they are doing culture also to know the resistance of the organism.
Yes.
If the
Because
if
sometimes
it's
the
resistant,
culture is negative in TB patient.
if negative TB PCR and AFB, so no TB for the patient. But
Okay.
okay.
And the problem is the culture is Dr. Basim is it take time. I think they make all together or
Isolation.
what do you think?
Yeah, they will do all together. The AFB
Yes.
and the culture TB PCR and the culture together.
Okay.
Once they
Yes, right.
suspect, they isolate and they will take all as a package. Okay.
Yes.
But since AFB 3 samples negative, they can remove isolation, but still they will wait for TB result, TB PCR, to confirm he is not TB, but he is not infectious as long as the AFB is negative. So
Yes.
can leave to go home or can be discharged or can live without isolation, but still a decision for the anti-TB will be pending the result of TB PCR, I mean. Okay.
Yes.
TB coming as a clinical case and coming also as a communication case. Sometimes they are asking to communicate with patient homeless. He's not compliant to the medication and he's open TB. What shall you do with him? You have to convince him. And you have to mention also the DOT team, direct observer therapy. They are a team visiting the patient and giving the medication by themselves.
Yes.
Yeah, this is one of the way how to be sure that the patient adherent to the medication and anti-TB compliance. DOT team or DOT therapy, directed observation therapy.
Yes, if the patient insisted to be treated at home.
Yes, they are giving every other day, 3 times a week. This is one of the communication scenarios. Okay. Any question regarding this? Dr. Abdulman, can you write the case down, please?
He wrote.
He wrote? Okay,
I
again,
have-
Mrs. Brandon. Yes.
I have one comment because the diagnosis of fibrosis because of the reputation are fixed is not accurate because some consultation can cause
Yes.
fine cavitation.
Transmitted,
so-
yes. Transmitted cavitation. Yeah.
Yes. So
This is also what Dr. Sarah said. Yeah. Don't stick to the location of the crepes or crackles.
Yes, and
It could be transmitted. Okay.
thank you, nice case.
Yeah, thank you, doctor. Thank you. Mrs. Brandon, 35 years old female, present with hand pain and fatigue. I will read the comment till you are ready, Dr. Sarah.
Mhm.
Okay. So she, especially with weight loss, yes. Unilateral fibrosis, maybe post-traumatic, post-irradiation, post-TB. Agree, yes. Ask about contact with sick patient. Yes. He asked already. He put TB down because he approached according to the lower and upper causes of fibrosis. Yes. But the history going more with the TB. And try to be your diagnosis, I mean your differential, you put the differential, the most serious up and the most common before putting it down. I mean, for this patient, if you suspect TB, it makes sense to put the TB in the top. And if you said, for example, sarcoidosis here, you'll be in trouble. Why you think about sarcoidosis with no symptoms or no signs? So try to be scientific and logic with the differential, because they are judging you on the differential. Once you put the differential against the case, they will minus the mark of differential diagnosis. Try to
Yes.
put the most common and the most related to the case, especially with some clues. As Bangladesh here, really, it's too much diagnosis. You will not find case in bases with Bangladesh or India or some endemic areas unless he point to some endemic disease, or travel to Canada, for example, long trip. So it will be guided due to PE. So always think about the scenario. What's written is very important. Travel history, so think about TB. If not, you suspect something related to the area patient was in. Malaria, for example, some African countries, whenever the country is mentioned in scenario, you should put it in your mind and correlate the case to the endemic area or to the country which where the patient was. Okay.
Okay.
And let's start. Yes, I
Yeah.
saw the scenario. Thank you, Dr. Abmanim. So I couldn't see it before. Let's start if you're ready. Timer
Yes.
started. Ready?
Okay. Hello. My name is Dr. Mahmoud. I'm one of the doctor here in clinic. Am I talking to Mr. Brandon?
Yes, Mrs. Brandon.
Mrs. Okay. I'm talking to Mrs. Brandon.
Yes, doctor.
Okay. So, Mrs. Brandon, can you confirm your age?
Yeah, 35 years old, doctor.
Okay. So, today I'm coming here to discuss about your health condition. I might ask you some question, and then I will examine you, and I will try with my best to address your concern and answer all your questions. Is that okay with you?
Okay, doctor.
Okay, Miss Brandon, I can see that you are coming complaining of hand pain and fatigue, right?
Yes.
Can you tell me more about that?
Yes, doctor. Yes, my hand starting to hurts me a lot, which I think for now is like 5 or 7 days. And at the same time, I feel this tired all the time, doctor. Then I went to my GP and he refers me to you.
I'm really sorry about that. It looked like quite distressing for you. But you have this hand pain in both hand, or it's only in one hand?
My both hand, doctor.
Your both hand. Okay. And is this pain started gradually or all of a sudden?
Yes, I think it's sudden, doctor.
And what do you mean by hand pain? What is the type of pain that you are feeling in your both hand? Is it
Actually, sorry?
is it the throbbing, stabbing, a spin needle?
Just hurts me a lot, doctor. Even I can't carry anything.
You mean it's burning pain?
I don't know, doctor. I can't just tell you the exact nature, but
Okay.
it hurts me a lot, doctor. All my hands.
In all your hands. It's only in, right?
Sorry?
It's only in your hands?
Yes.
Any pain other part in your body, in your leg?
No.
Okay, and this hand pain, is it related to specific time of the day, or it's all present?
No, doctor.
Anything make it worse?
I didn't notice actually.
Anything make it better?
No.
And this pain, when you are moving your hand, it's increasing or it's improving?
I didn't notice actually, doctor, but I didn't notice anything make it better. But this all the time, continue all the time, this pain.
Okay, and for this pain, you have you noticed also with this pain stiffness in the joint of your hand?
Yes, doctor.
And is this stiffness a specific time of the day or all the day?
All the day, doctor. But I think more in the morning.
So you have stiffness more in the morning. Any pin and needle sensation in your hand?
No.
Okay. Just to ask you some question, yes or no, if you don't mind. You have you noticed also when you are exposed to cold, your hand become more painful?
No.
Any rashes in your body or skin changes?
No.
Any dry eye?
No.
Any dry mouth?
No.
Any difficulty in swallowing?
No.
Okay. Any shortness of breath?
No.
Any heart racing?
No.
Any chest pain?
No.
Okay. And okay. And any change in your bowel habits?
No. No.
Any change in your water work?
No.
Have you noticed your urine color is changed or painful
No.
or
No.
not frothy?
No.
Okay. And have you noticed any ulcers in your mouth or in your private area?
No.
Have you noticed your skin is become more tight?
No.
Any lumps or bumps on your body?
No.
Any fever?
You mean body temperature?
Yes.
Yes, doctor. I think it's I feel this my high body temperature 3 days ago, or I think at the same time, doctor.
So you was having fever for 3 days ago, and you are checking this fever, or you feeling your body like this?
Sorry?
You are checking the temperature?
No.
Okay. Any lumps or bumps on your body?
No.
Any change in your weight?
No.
You didn't gain weight or you didn't lose weight, right?
But I think I lost some weight, like 1 or 2 kilos
For how long?
in the past 2 months.
2 months. Okay. And this was intention?
No.
And you told me you have this fever for 3 days. Is this fever continuously or it's coming and going?
It's coming and going. It's
And
not like 3 days. I think it's started at the same time of my hand pain, doctor,
7.
or just precede my hand pain.
Okay. And anything relieves this fever, or it's go on its
I use paracetamol, doctor.
paracetamol? Okay. And just some question regarding your health. Do you have any medical condition I should be aware of?
Yes, doctor. I have rheumatoid arthritis.
You have rheumatoid arthritis. And since when you have rheumatoid arthritis?
It's like I think they diagnosed me 6 months ago.
6 months ago. And
Yes.
what medication you are taking for rheumatoid arthritis?
I'm taking 2 medication, doctor. One of them called hydroxychloroquine, and the other one sulfasalazine.
Sulfasalazine. Okay.
Mhm.
And are you compliant with your medication?
Yes, doctor.
Any side effect that the doctor told you about the medication you experience?
Sorry?
Any side effect of the medication you experience?
Like what?
For the hydroxy, I think the doctor have discussed with you the side effect of the medication before giving you the medication. Any side effect from this in your eyes, vision, or any?
I didn't notice anything.
Okay. And how is your rheumatic activity is controlled?
Sorry?
How is your rheumatic arthritis is controlled?
Yes.
And when you was diagnosed with rheumatic fever, what symptoms you was having?
Rheumatic fever. Sorry, again, rheumatic fever, doctor, or what?
Sorry, rheumatoid arthritis. What symptoms you was having?
At that time,
Yes.
yeah, I have this, I think, hand pain, and
Mm.
I have noted that even my fingers it's become this. The shape of my fingers have been changed.
Ah, okay. Do you have any medical condition apart from rheumatoid arthritis?
No,
And any medication apart from hydroxyurea and sulfasalazine?
no,
Okay. And just question regarding your lifestyle. Do you smoke?
smoke? No. Yes, yes, doctor.
How
I've
many
been smoking for the last 10 years,
cigarettes per day?
like 5 to 10. Depends on the stress.
And you sorry about that, but I just want to tell you that smoking can affect rheumatoid arthritis and can cause increase the activity of rheumatoid arthritis. So I highly advise you to stop smoking, and I can refer you to the smoking cessation clinic. They have a good service and can give you medication to decrease your craving for smoking. Are you happy to do that?
Yes, I will do my best, doctor.
Okay, and what about alcohol? Do you drink alcohol?
Yes, doctor.
How many units per day?
Like 7 or 3 to 5, doctor.
But you are aware about the recommended dose of alcohol, which is 14 units per week. Are you aware of that?
Yes.
So I think you are taking more than the recommended. So if you are able to decrease it, because also it will affect the rheumatoid activity.
Okay.
Okay. And what do you do for a living, Miss Brandon?
I'm bank accountant, doctor.
And how is this condition affecting your work?
It's affect a lot, doctor, because since this problem started, I have this severe tiredness, and I have some sort of lack of concentration, and sometimes I couldn't go to the work.
I'm really sorry about that, but I assure you that we will help you to get the bottom of this. And what about your period? Is it regular?
Yes, doctor.
And are you pregnant by any chance?
No.
Are you taking pills?
No.
Pills? Okay. And do you have children?
Yes, doctor.
How old are your children?
The last one, 6 years old.
6 years old. Okay. And just what is your main concern from today?
My concern, doctor, why this happened to me in spite of I'm taking my medication regularly.
I really appreciate you.
And doctor, for how long should I take this medicine?
You mean the medicine for rheumatoid arthritis, correct?
Yes.
So I highly appreciate your concern. I will address your concern while examining you, and then I will try it. But after examining you, I might have a proper image in order to answer your question. Okay. So I would like to check the vitals.
Just let me send the image of her hands. Vital or normal?
Vitals are normal. Okay.
Mhm. Are you able to see the picture in the chat box?
Yes. Okay.
Mhm.
Yeah, so this is her hand. Okay, I can see one subluxation. Okay. So I would like to examine your hand. So can you put
Mhm.
on your lap? Okay.
Put what?
Your hand on your lap. Lap.
Okay.
So I will examine the joint of the hand for tenderness.
Mhm.
Any tenderness?
Yes.
Okay. On which joint?
In the proximal metapharyngeal joint.
Proximal metapharyngeal joint. Okay. And then can I ask you to do a prayer sign?
To do what?
A prayer with a prayer sign.
Okay. Mhm.
An inverted prayer sign.
Mhm.
Okay. Now I will ask you, can you hold this coin?
Impaired.
Impaired. And I will like to put a piece of paper between the finger.
Mhm.
She's
What
able
else?
to try to take it. I'm able to take the piece of paper.
No.
Okay. So and also I would ask her to do some movement of her hand by make the thumb approaching every finger. She's able to do that?
No.
Okay. So, and I would like to check the pulse.
Also, it's 84 regular.
Okay, and check if I would like also to do neurological examination of the hand to check for sensation, for model of sensation.
For what?
Is a full model of sensation, fine sensation, pinprick, vibration,
Intact.
position,
Intact.
intact. Okay. I would like to have a quick
You would
look.
like to do vibration for what? For which joint?
Well, I check the vibration sense.
Okay. For the hand.
Yes, I will check it in the finger because I need
Okay.
to check all the sensation in the hand.
Okay.
Okay,
Okay.
and then I would like to check the chest for crepitation,
There is bronchial breathing in the
bronchial.
middle. Yes.
Okay.
In the right side of the middle, mid zone of the right lung.
Bronchial breathing in the middle zone of the right lung. Okay.
Mhm.
Okay, I would like also to check the hand for any rheumatoid nodules and the elbow.
Negative.
Negative. So also I would like to check with the mouse for any disfigurement, any ulcers, any small opening mouse.
No ulcers.
The eye for dryness or any redness.
No, nothing.
2 minutes left.
Okay, so and I would like to examine the lymph nodes in the neck.
Negative.
Okay. So, Mrs. Brandt, after examining you, I think you might have your rheumatoid arthritis is not controlled with the medication. Okay. So I would like to run for you some tests. And also it might be related to the smoking and might be that the drug that you are taking are not working well. So I would like to run for you some tests and do some imaging on your hand. And I will exclude the multidisciplinary team. I will ask the rheumatoid doctor and also the physiotherapist and occupational therapist, so we can put for you a good plan for your treatment. Okay. How does that sound?
Okay. So, doctor, as you told me, might be this medicine not okay for my condition, so I are going to change my medication.
Yes, I think the rheumatology team will be at the best position to know that.
But doctor, I was using it all the last 4 months and nothing. It was very controlled. Why I'm having this, doctor?
This is a good question. It could be related also to the smoking, because you are still smoking, and smoking can not let this medication work well and increase the activity of rheumatoid arthritis.
Okay.
Do you have any other question for me?
No, thank you, doctor.
Okay, time is up.
Okay.
Let's go to the examiner questions.
So present your case.
So I examined this lady who's presented with 7 days history of pain in her hand and pain in her hand and fatigue. So she has a history of rheumatoid arthritis. On examining her, she was having a picture in her hand of rheumatoid arthritis in the form of joint subluxation and swelling and with pain as metacarpopharyngeal joint. Her neurological examination was normal. She has a normal sensation in the 4 modalities. She was having mild bronchial breathing in the middle right zone of her lung. So putting this all together, and also she's compliant with the rheumatoid arthritis medication. I think that this patient might have rheumatoid activity. This is my top differential, and I need to to confirm that by doing for her full blood count, renal function, liver function, ESR, CRP, and TCCP to detect the activity. And for the treatment, I include multidisciplinary team, include the rheumatoid, the nerve doctor, the rheumatology team, and the physiotherapist and occupational therapist for further planning for her.
Okay. What's the differential diagnosis of fatigue for this patient?
Fatigue. Okay,
Right.
it could be from rheumatoid arthritis. It has many causes. It could be she might have anemia of chronic illness due to rheumatoid arthritis itself. It could be this fatigue could be related to the lung with shortness of breath. If she has some complications from rheumatoid arthritis. This is my cause of fatigue.
Okay. What is the differential diagnosis of fever?
Differential diagnosis of fever for this lady?
Yes.
It could be rheumatoid activity. It could be arthritis.
Again.
Arthritis.
Differential diagnosis of fever inside this lady.
For this lady,
Mhm.
differential diagnosis fever. It could be rheumatoid activity. It could be yes, she might have arthritis and infection in the joint. She might have chest infection. This is
What else?
fever. Chest infection.
Okay.
Hmm.
So, in general, what are the causes of flare-up of rheumatoid arthritis?
Yes, I think the cause of flare in compliance with the medication, or the patient might smoking. For this lady, smoking also it could increase the activity and also it increase the NTCP, which both can increase the flare of the disease. And poor compliance, or if the disease is severe and need to include she's taking to the disease modifying agent, we need to add another medication or change it to the biological treatment. And could be also the alcohol that she's taking.
Okay. So you mentioned that you are going to change her medicine or her anti-rheumatoid arthritis. What medicine could fit her condition?
She's taking sulfasalazine and hydroxychloroquine. We can one of them to methotrexate.
But this lady wants to get pregnant, doctor.
If she wants to be pregnant, no, she can continue on hydroxyurea and sulfasalazine. This is the two medication. Hydroxychloroquine and sulfasalazine. This is the two medication for could be
Any other drug can be safe in pregnancy?
hydroxychloroquine, sulfasalazine. Azocyprine.
Okay. If this patient presents with neck pain, what could be the cause?
Cervical spondylosis.
What else?
Neck pain, cervical spondylosis.
Or I mean, serious complication of rheumatoid arthritis.
Yes, atlantoaxial subluxation.
Okay. How you are going to investigate this lady?
For this lady, I will do for her the routine full blood count, renal function, liver function, and also I would like to do for her CRP, ESR, and TCCP. She might need an X-ray on the joint to check the rheumatoid arthritis activity in the joint, which is subluxation, sclerosis. Yes.
Okay. What else?
And we need to have a chest X-ray and high-resolution CT scan to check for interstitial pulmonary fibrosis. We need also this patient we do for her eye examination, eye examination for hydroxychloroquine side effect. This is
Okay. Okay. What's the treatment?
The treatment will start with the disease-modifying agent. First, we start with one medication, and then we can add the second one. And if it's
If this patient presents with newly diagnosed of you just diagnosed her with rheumatoid arthritis, how would you manage her?
how we will manage her? First of
Yeah,
all,
in acute stage.
yes, we will. We can give her steroids at the beginning to decrease the inflammation. With
For how long?
maybe for 2 weeks.
2 weeks.
Yes.
Okay.
And then we will give her the disease-modifying agent.
Would you like to add anything besides this steroid?
Yes, ممكن a non-steroidal anti-inflammatory medication.
For how long?
I think maybe for it's not for 1 week till the medication will work, also the activity and inflammation of the joint will subside.
Okay. Okay.
Okay.
Yes, already the time is up for the questions. We'll hear the
Okay.
comments. Well done, Doctor. Sorry, Dr. Omni, I want to say this because Dr. Sarah, first time, she consumed 15 minutes for history and examination and concern. Yeah, really,
You know what,
you
Dr.
did it
Batim
today.
disappeared last diet. Patient already known.
Yes,
Your task is not to diagnose. That's what the problem. Your task is not to diagnose rheumatoid arthritis.
infection.
Your
Yeah,
task is
infection.
to
Yeah.
determine why this patient presents with flare-up. What is the trigger?
I know.
So
I stuck with that. I think it's
Yeah.
not. Have you?
Yeah, let's hear the comment. Then
Mm.
I will comment. Yeah, you can start, Dr. Omni.
Okay, just I want to give you advice. In recently, I think the scenario for LCC has been changed. If you have any case with spot diagnosis, either, for example, Marfan or acromegaly or rheumatoid arthritis, after you analyze your initial symptoms and after finishing the system involved, immediately ask about do you have any past medical illness I should be aware of? To know your task. Is it to diagnose the disease or to know the complication or the flaring up or whatever, the precipitation or triggers? For such scenario, your task is not to diagnose because patient already has diagnosis of rheumatoid arthritis and on treatment. So your main task to know to looking for complication and triggers. And in patient, the trigger was a pneumonia, which is the infection. You didn't give more attention about the fever. You just ask her.
It doesn't have cough or only fever. Because
You didn't. I write it here. I write it down. You didn't ask me about cough.
Okay.
Yes, because you mentioned, I think, almost all the symptoms of pulmonology, but you didn't ask me about the cough. I have cough and fever. So he is precipitate. But the good things, you ask about the other trigger of the rheumatoid arthritis. You ask about exercise, because it's vigorous exercise or heavy exercise can trigger, and even sedentary lifestyle can cause or trigger in this rheumatoid arthritis. The other triggering factor, infection and non-compliance. This regarding the trigger for rheumatoid arthritis. Regarding the examination, you didn't look well for disease activity. If you ask me about the swelling, I would inform you that this has swelling. So, I mean, generally speaking, about the activity of the disease, which is tenderness. I have tenderness. I have swelling joints, which is boggy sensation in the both and four fingers. This regarding the activity, the deformity already mentioned, and which is I think it's minimized in abbreviation DAF, deformity, activity, and function. You already ask about deformity and function. I don't know why you ask about vibration and the other thing, for carpal tunnel syndrome.
I checked. The Fallon and Tennant. I said for the inverted prayer for the carpal tunnel, and also when you examine, there is some examination for rheumatoid arthritis hand by make it
Yes, carpal tunnel is associated. Why not?
For carpal tunnel.
yes,
Yeah.
for carpal tunnel, and also I think there is examination, specific examination for the hands for rheumatoid arthritis by checking every joint, ask them to do some movement, and if they are able to do inverted prayer and prayer sign, they won't be able to do that. So this some
Yes.
and
Yeah, this thing, yes, for the function, but he mean
Mhm.
about the swelling and the pleural effusion. Sorry, the effusion, joint effusion. You didn't examine for that.
Yes.
You should
And the other thing,
palpate
patient
every
have
joint. Yes.
patient has fever. Definitely you should examine the abdomen for splenomegaly, for faulty syndrome, neutropenia, and splenomegaly. It's important, very important to ask about and to examine. You have to, because what I want to say, if patient with rheumatoid arthritis has fever, take it serious, because he already immunocompromised, has many causes of fever, so you should looking for it or to ask about the differential of fever inside patient with rheumatoid arthritis. For fatigue, I think fatigue is jargon. So when you ask the patient, ask about tiredness. Fever, just to be on the safe side, yes, it is not jargon fever, but I think it's better to say high body temperature to be on the safe side. You asked me before, I don't know, but for me, it's better to ask concern at the end, because exam is the stress of the exam. You're definitely going to forget one of the concern, and sometimes even surrogate you will not repeat the concern. I gave you two concerns. The first one, what's wrong with me? The second concern, for how long I should continue my medication.
yes,
And because of stress, you definitely will forget. For me, I prefer to say it at the end. Yes, I know some people just mention it before when finishing the history, but because the stress of the exam, it's better to ask it at the end. For example, here you forget one of the concern,
yes,
and
right.
yes, and in many cases, I don't think they will repeat the concern again. So
Okay.
don't put your header for managing concern, because no one wants to put this in the feedback. Regarding the investigation, you covered it well. Regarding the treatment too, and yes, for this management, I'm not sure if it's wise to say to the patient, we need to change the medication. You should involve the rheumatologist to
Yes.
revise the medication.
Okay.
No, I think I'm not sure about this. Let our colleague comment on this part. Is it wise to say I will change your medication or no? But I don't think that.
Yes,
Uh,
rheumatology should be involved. Yes.
yes, this is my comment. Otherwise, you did it very well.
Yeah, thank you.
I did
Thank you, Dr. Min.
diagnosis.
Sorry?
I didn't get the diagnosis.
No, but sometimes it's not necessary. At least you did the approach. You know there is
Yes.
something hidden. In this
Yes.
patient, you reach there is activity or something different, which also related to the immunosuppressant medication. So I guess you will get good mark, not bad one. But don't forget you are still preparing. You didn't finish your training. So
Yes.
still you are learning from here better than in the practice in the exam, okay?
Yes, you're right.
Let me comment. Yes, as general performance, you did very much better than yesterday and before.
Okay.
You utilized the whole 15-minute examination and history. You didn't miss any of the history. I guess also the family history, you forget the family history?
No,
I can, you forget, sir? Yeah,
You
the
forget,
social
yes.
network.
Yes.
Yeah, the family, the travel. Always remember the mnemonic, okay? The mnemonic I mentioned before, Fatma. At least, yes, you can. It can help you to reach. Some patients will have rheumatological condition in the family, so she will tell you, yes, my mother was rheumatoid arthritis, and
Okay.
always start any past history I should be aware of, any medical history I should be aware for you and Dr. Abdul Menaim, because also Dr. Abdul Menaim case was signifying the diabetes and hypertension, immunocompromised patient as diabetic one, and in this case also this question will help you a lot because you spend a lot of time asking for rheumatoid, which is already she's diagnosed with.
I can
So
see
better to ask.
I was analyzing.
Yes, exactly. You analyze the pain and she's already diagnosed. If you know the rheumatoid, you will go through the question of rheumatoid. Any stiffness? No. Any electric like shock pain for carpal tunnel? No. Any deformity? No. That's it. The pain itself, character, yes, you can ask, but if she deny, you can get from the diagnosis. Plus, for the carpal tunnel, you can say the shakiness of the hand resolve or reveal, relieve the pain. Yes, doctor. So this is carpal tunnel because sometimes the carpal tunnel coming as a case. And for the
Mm.
Raynaud, you will ask any cold exposure might lead your hand to be a change in the color. This is for Raynaud. And burning for pins and needles for peripheral neuropathy. That's it. So the question will be more, uh, I mean, clear for you. Let's go to the scale of pain. Any pain, you have to give scale for the patient and you can offer painkiller whenever the scale more than 5. For Dr. Abdominal case, yes, I forget for the short of breath. Whenever you have patient with short of breath, you can tell her or you can ask her, are you comfortable now? Do you need some oxygen support? Do you need some are you okay like this? Okay. If you know, doctor, I'm short of breath, you can offer oxygen. Yeah, we can connect her to oxygen. Okay. These things make your performance impress the examiner that you are looking after everything in the patient, not only the history. Even the patient is short of breath in pain, you are taking care of these things. Okay. Let's go back to the rheumatology screening. You screen the all rheumatology, skin tightness, and this is also good thing you did today. Chest tightness, and buckling of the nose, difficult swallowing, mouth sores, the eyes. So you were thinking about mixed connective tissue disease, which you learned a couple of days ago. Yes.
Yes.
Yeah. So you learn from that, and you did it today, which is practically well. And by this way, you will not forget any rheumatoid association.
Yes.
Apart from this, the chest always ask. There are 2 questions for the chest: short of breath and cough. Whenever you ask one of them, ask the other. Short of breath or cough. Most of the chest patients, they will present either short of breath or cough.
Yes.
Unless this is chesty patient, I mean, he has respiratory symptoms, you will ask the all question for respiratory, like wheezy or noisy breathing, or any phlegm, or any blood coming with the cough. But in general, if you suspect or if you want to screen system review for the chest, you can ask 2 questions: any cough, any short of breath. That's it. If you have positive, you can screen more for the relevant system, which is the chest, and you can reach to the diagnosis. The constitutional symptoms here is a clue for the fever, and you can also loss of weight. You can find loss of weight, and the fatigue itself, you have to screen for. Once you have 2 symptoms or 2 complaint in the scenario, you will screen one by one. Hand pain finish, then skip or jump to the next complaint, which is fatigue. Fatigue, you can ask if you are feeling tired. Fatigue itself, as jargon, as Dr. Abdulmanam said. So tell me, since when you are feeling tired? Doctor, from 6 months for according to the duration, and it will be associated with any rheumatoid patient or any connective tissue disease patient or autoimmune patient. Okay. What's make you better? Are you able, whenever you have fatigue, also you have to ask about the daily activity, the impact on the life and the job. Of course, you ask for the job, but for the daily activity is very important. Do you need something at home? Anyone, how you are coping with your activity at home? Anyone supporting you? Do you need any support? Also, this one will impress the examiner. This is for the occupational. The other system you did for the urine, as it might be associated with amyloidosis, as we know. Also, female history is very important in this patient, particularly, and in any patient in the childbearing period. You have to ask about the period, the birth control pills, any pregnancy, or any plan for pregnancy in this patient. make sense that you asked about, are you planning for pregnancy? She's on methotrexate, which is a teratogenic medication. You have to offer holding the medication if she's planned, or you have to offer stop planning for pregnancy or postpone until the disease is controlled, or to be followed with a fertility doctor or woman doctor to arrange another medication which is safe during pregnancy, to have safe baby and safe pregnancy. You have to specify your concern about pregnancy if she asked, but if she didn't, you have to do, because this is for the welfare, is very important. Okay. So
Okay.
female history in 30s, especially 30s, female 30s, you have to ask about female history, full female history. Any miscarriage also is very important here to rule out antiphospholipid syndrome. You might have association with rheumatoid arthritis. Okay. Other joint pain, other joint activity, skin rash, all the things you should ask. I guess you didn't ask for SLE, the skin rash in sun exposed area. So you have to ask this question.
Okay.
Okay, the examination, look, feel, move, as we know, look, feel, move. You did the look and the movement, but you didn't feel. You have to feel every joint. It's,
Mm.
yeah, acting only. Touch it and touch it by your dorsum of your hand up above the wrist, I mean, to compare the temperature. Of course, you will not feel anything, but just to show the examiner that you are feeling the temperature at the joint and above the joint. And if you suspect tightness of the skin, you have to pinch the skin. If you have any tightness, you have to go up above the elbow if you suspect systemic sclerosis.
I think
Let's
we'll
go to
ask
the,
her to pinch the skin because it's not ethically to pinch the skin for her. You can ask her,
yeah,
can
you have to ask.
your skin?
Yeah, yes. Can I
Okay.
do? Yes. Okay,
No, she
let's
will do it
go.
for herself.
Yeah, you ask her to to pinch her skin. Yes,
Yes, yes.
agree. Yes, agree.
Okay.
Okay, let's go back to the look. Finish the look. The deformity, you have to mention any deformity in this hand. You didn't
Mm.
say any of them. Z-shape thumb or boutonniere or swan neck, you have to mention. Or
Mm.
ulnar deviation, all this deformity might be there. The good thing here, you ask for a rheumatoid nodule, either in the olecranon or at the hand. You mention it and you examine for it, but you
Mm.
have to mention it. Any rash also in the hand, if you suspect dermatomyositis as well, you can find Guttron papule
Mm.
in the hand, I mean. So you have to inspect the hand well. Then the function, as you said, prayer, reverse prayer, or pick up this coin or the pen or whatever. You
Mm.
can do also for the thinner activity as you did,
Mm.
and the wasting of the hand. Sometimes they are associated with some wasting in the muscle, the hand of the muscle, or the muscle of the hand. Okay.
Mm.
Carpal tunnel, you have to offer. Can I tap here if you have pain? No. You can tap. Any pain here? No. So you rolled out carpal tunnel. This is for the rheumatoid arthritis, and you should do it. Let's go to the back of the chest. For as you discovered that crackles. So can you ask, or you can ask for cough? Can you cough for me? It disappear. So if not disappearing, this is going with fibrosis, interstitial lung disease association. Or in this patient, it might have, or she might have crackles, which is cleared by cough as pneumonia case. Okay.
Mm.
Yeah, lymph node, good thing you examine the face for any association, SLE, the eyes, redness in the eyes, Sika syndrome, dryness, Sjogren. You have a lot to examine. And the abdomen here, you will ask for for splenomegaly, for Felty syndrome. Then the knees for also any association of osteoarthritis or any rheumatoid activity also in the leg, and leg edema for any core pulmonale or heart failure. That's it. The good thing here in this patient, you did a lot to examine, you did a lot to screen and take good history. Yes, regarding the alcohol, you ask how many units per day which is not the perfect or proper question. The proper question, how many units per week? And you already told her, are you aware about the social limit, which is 14 units per week, right?
Yes.
So if you want to ask, you can ask how many
So
units per week. Yes, better.
But usually when we are asking here in real life, we are saying how many units per day.
So you are, yeah, then you are
But here,
multiplying by
family-
7. Yeah.
yes.
Yes.
So that's why I was thinking like this.
Maybe because we are not here familiar with the alcohol, so we are asking in the week. But for you, of course, they are drinking daily,
Yes,
so
that's
you
why.
can ask per day.
Mm.
Yeah, but suppose it will be socially at the weekend. But as you, yes, you're right. Sometimes in UK, it's a
Yes,
habit, so they can open eyes with alcohol. Yes, you're right. Okay, whatever. So 14 units per week at the social limit, you have to give advice about. I think we covered this case well, and it was good case by Dr. Abdulmenem, and also good performance, both of you today.
I just
Any
want to
comment
ask
or any question?
this.
Yes.
This now I'm doing 15 minutes and I'm not doing real examination. In the exam, it will be real examination. It will take more time. And the patient will talk, I think, more than this
Yeah.
question. So
Yes. So,
all this question, how we'll manage to ask all this question and do true examination? I think
so yeah,
I
I
think
will give
in
you
the
the.
exam, for example,
this
if you would
patient,
like to do abdominal examination,
Mm.
you can offer to examiner first. Sometimes they can say, just skip it, but you have to offer. The important thing, for example, you can do a hand examination quickly, but the other system, for example, eye symptom, in this case, such there is no any eye symptoms, offer to examiner, because most of the case they can say no need. This can save sometimes, sometime in your exam.
okay. And also the history is very. So I didn't ask
No, no.
actually
Let,
because I
let
think
me give you this advice, Dr. Sarah. The face-to-face is different than the online. Face-to-face, the question is always followed by answer, so it will not use or utilize more time. So you have time. Yes, I faced in the exam. I finished and I did examination, and the concern at the 2 minutes, everything
and
was
you
okay
didn't
because the
practice face-to-face long clinical consultation because
no,
I'm thinking
only the exam.
only in the exam and you finish in time, right?
Yes, and try as soon as possible to go to do the examination. No one will prevent you from examining the patient. And if you finish, you can go back to take the remaining history, or you can take history while do examination. If you sit down, you can ask again, can I examine something I missed? Everything is allowed because this is your right. 15 minutes, this is your right. 5 minutes, the patient, the
They
examiner writes. Yeah.
they
No,
won't
no,
have
they don't.
that I'm disorganized when I'm jumping from this and
No,
this.
no, no. This is your at least he will do better than not doing. Okay. And
Okay.
for the concern, yes, it's okay to you can ask at this point, Dr. Abdulmenem said some surrogate will not give you a concern. No, this is your right to know the concern. Anytime you have to you will ask the surrogate, what's your concern? He has to ask you. He will not hide you, and he will not hide the concern, and he will tell you, no, I said already earlier, no. You're right to know the concern. No one can prevent this or hide the concern from you. So you can ask earlier and to prepare yourself for the answer. Then, if you have good time, of course. And at the end, 2 minutes, again, ask him, can you tell me again what were your concerns? Yes, doctor, I am concerning 1, 2, 3. But
Yes,
he
and
will
also
hide? No,
yes.
he can't.
They said also don't say I forgot while examining. You can say if you forget to ask the patient something, you can say it as while are saying, if I have time, I would like to ask the patient about that. Or if I would have time, I would like
Yes, yes. If you miss
to
something
say
and you
I
remember,
forgot to do that. No, say if I will have to make yourself confident. If I will have
yes,
might ask him if I have time, I can examine this. If you forget,
yes, yes. So in this patient, the mandatory thing to do to examine the hand and the chest.
yes,
Others either by offer or by if you have time you can do. But
okay,
apart from this, yeah, this is the most important system you have to examine, and they will minus you if you didn't. although also according to the examiner, which I don't know how the examiner there in UK, but some examiner are tough and they will minus you for any small, tiny things. Sometimes also naive things. Anyway, try to do optimum history, optimum examination, and the concern always ask it whenever you hear 2 minutes left, because the concern separate marks. Okay.
Okay.
Yes, let's read the comment. Any question, Dr. Abdul Menaim?
No.
Okay. Oh, okay,
Thank you.
thank you. All autoimmune okay, thank you. All the autoimmune profile should be requested, yes, of course, as investigation. And the activity is very important question. What the investigation of activity, Dr. Sarah, in this patient?
I think ESR, anti-CCP. I'm not quite.
Yes. Yes, anti-CCP, yes.
Mm.
Yes, that's right. In the exam, my case was diabetic patient. Examiner let me only do sensory examination. All other told me no need to do. Yes.
Okay.
It's according to the examiner wish. In my exam, the examiner asked me why I didn't do abdominal examination in Charcot joint patient. Of course, he was very tough. I don't know what's his nature, but I think he was sick.
Yes, you said.
Really, if abdominal for gastropathy, what I will examine in the abdomen?
Nothing.
Nothing. What I will find, yes.
Maybe
Even
fatty.
the patient has
Maybe he was saying
fatty
about
liver, okay. Fullness, fatty liver, whatever. It's not the complaint and it's not the significant association or significant complication. Anyway,
Okay.
hopefully you will not face like my examiner in your exam.
Any news about the appeal or anything or nothing?
No, still no.
Okay.
Seems like they are neglecting and
Mm.
okay, thank you for the session and the comments. Thank you, Dr. Sarah, Dr. Abdul Menaim.
Thank you, Dr.
Any
Abdul Menaim.
question from others? Any comment? Okay, if no comments, we can end the session. See you tomorrow, inshallah, with another day of practice.
Thank you very much.
Good luck and good night. Most welcome. Thank you. Most welcome. Okay, thank you all. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.